you very much. Thank you for the opportunity to speak today and the invitation. And before I get on to too much of it, the fact it says cancer research at the bottom, what we're here to talk about today is disease agnostic. I don't want people to think that that's the only area that we're going to focus on. So Simon and I are going to do a bit of a double act, talking about some of the innovation in rare disease clinical trials that we're involved in Birmingham. So as a very quick recap, I'm sure everyone's up to speed, but just in case. So rare diseases affect about sort of fewer than 1 in 2,000. That's the definition we generally use, but there's sort of a very long tail. They get very rare very quickly. And there's over 7,000. I normally update it with whatever number the last person said, about 7,000. So this means that in the UK, there's about 3.5 million. Overall, that's about 1 in 17 people will be affected at some point in their life. And we find that generally these have been neglected by research because it's thought that this is an area that's too difficult to do clinical research because the potential patient pool is too small, the possibility for reimbursement and to make a profit from drug companies is just not there. And it's also quite difficult because clinical trials generally require large numbers of patients. And what this has ultimately led to is there being a really poor evidence base for treatment. And, everyone deserves to have treatment decisions made with them based off of the best quality evidence that's available. And often that isn't what happens because that research simply hasn't occurred. This is one of my favourite reviews and I use it often. So about 5 years ago, someone did a review of all the clinical trials that had been registered since 2000, and they found there was about 28,500 clinical trials in rare diseases that had been done in about 1,500 populations. So if there's 7,000 rare diseases, that means there's only been a clinical trial in fewer than a quarter of them. And for some context, in the same period, there was over 500,000 clinical trials in common diseases. If you also look into the numbers behind that, it's very inequitable in terms of the diseases that are studied. There are a couple of diseases in there who had thousands of clinical trials, and sort of most diseases that were studied only had one or a couple of trials run. There was also a preference for cancer-related rare diseases, very much mirroring the sort of idea that a lot of innovation generally happens in cancer first and then is transferred over. They pretty much all retrofitted classical designs, which meant, again, there was more of a preference for some of those more commonly rare diseases. And I've just put a little bit of, given we're at a repurposing conference, over the same period, there was another review done that found that of all of the drugs that were approved in Europe, for sort of orphan designation, about 20% of them were for repurposed treatments. So it's, historically not been a particularly attractive area to do clinical trials. And so there are a number of initiatives that were launched recently that I'm going to talk a little bit about. So I'm going to start by talking about Rare Disease Research UK, and then I'm going to hand over to Simon, who's going to talk about the LifeArc Translational Research Centres for Rare Disease. So Rare Disease Research UK was a platform that was set up by the NIHR and the MRC through joint funding in 2023, and it consists of what we call 11 research nodes or 11 research groups, all coordinated by a hub based up in Newcastle. So you can see on the slide there are 11 different research groups. The ones who have got a red logo means they are investigating a particular disease or a certain disease pathway, whereas the green ones are agnostic of diseases, so they're looking at all of them. We are up here, and what we are looking to do is change clinical practice through innovative trial designs. So we're looking at just how small we can make clinical trials in rare populations while maintaining that statistical and scientific oversight and rigour to ultimately create a step change in the ability and the number of clinical trials that are designed. So the CAPTIVATE node is a collaboration between researchers at the University of Birmingham, Sheffield and Liverpool. We also have a mix of statisticians. We're generally dominated by statisticians, but we do have some clinical expertise. And similarly, we have a project manager who keeps us all in line and tells us what we should be doing and when. All of the research nodes on the rare disease research collaboration are focused around sort of multiple projects. These are the ones that we are specifically looking into. So the first one we're looking into is, can you do one clinical trial that encompasses all of the different phases? So from one clinical trial, can you work out safety, dosage, efficacy, and superiority to current standard of care? This obviously has a lot of benefits from a logistical point of view because you're not having to set up multiple trials, so there's a certain economy of scale. We're also looking at maximising the benefit of external information in rare diseases. So here we're looking at where we can use external data sources. So in the repurposing setting, that might be how we can use information from the clinical trials and from evidence that's out there on usage of the drugs currently in a new population. It might also be how we can use information from the adult setting if we're looking to repurpose in children, and also how we can use preclinical work. As part of sort of Project 2, we're also working with the NDRS, so the National Disease Registry Service in the UK, who are currently setting up a overarching rare disease registry to collect information as part of standard of care on all rare diseases. So we're looking at how we can use that information both in trial design and also in the running of trials. And then our final project is looking at just how small we can make sample sizes. So just how small a trial can we actually run while maintaining that oversight, that rigor, and making sure that the conclusions we draw are accurate and robust. We're also looking at how all of these interchange and how they work as prevalence decreases. So as you get more into the ultra rare and into the N of 1 conditions, and therefore how the treatments you're giving differ. So if you're giving individualized ASO medicine, how some of these things play into fact there. And the culmination of all of this is that we are developing a library of resources that has a variety of training materials, generalizable protocols, guidance for setting up setting up disease studies, case studies and examples, and packages and analysis programs so that other people can do them. Because it's no point just us knowing how to do this. We want to make sure that that's available worldwide. And running alongside all of those projects, we acknowledged that there's no point us just doing this if what we were coming up with wasn't appealing and fulfill the needs of others. And so as part of this, we have held 3 working groups and 3 focus groups, and we are planning on repeating this exercise again towards the end of the project. So the first focus group we held late last year was focused and invited people living with and caring for those with rare conditions, as well as those who had previously had rare conditions. And here we talked about the public's perception of clinical trials, the public's perception of outcome measures, trial designs, uncertainty, because when it comes to uncertainty in the rare space, unfortunately, the uncertainty in whether a treatment works is generally what increases. So we were looking at if we could, what level of uncertainty would be willing to accept. We also our second focus group was with trialists and methodologists, so we could understand what they wanted from trials in rare diseases and what compromises they would be willing to make. And the final one that we've got planned for later this year is with industry, regulators, policymakers, and government agencies. So this is, can we make a step change in the legislation around clinical trials in rare diseases so that they are more feasible, so that the goalpost isn't just shifted slightly, it's actually achievable. And again, we're looking at this about how that changes with prevalence of the disease, and we're currently in conversations with a couple of regulators in preparation for this meeting. I'm happy to talk about any of those if anyone wants. And with that, I'm going to hand over to Simon.
Thanks very much, Tori. So I'm going to talk a little bit about the LifeArc Acceleration of Rare Disease Trials initiative. This is going to be much more about advertising than about science. I should say we're both statisticians, but we're not going to talk about statistics. It's a slightly unusual position for me to be in. So this LifeArc Centre is one of 4 translational research centres for rare diseases, which LifeArc have funded recently. 3 of them are clinically based. This one is methodologically based, and it's all about trials and trying to improve the conduct of trials in rare diseases and make more of them happen. So the aims are essentially that, to make more rare disease trials happen, to improve the evidence base for treatment of rare diseases. It's a collaboration between 3 universities in the UK, Newcastle, Queen's University Belfast, and the University of Birmingham, where we're both from. And the formal aims just listed there on the slide. So establish a UK-wide trials acceleration platform, and I'll say a little bit more about that in a minute, to facilitate recruitment into trials of people with rare diseases and to design and deliver innovative rare disease trials. The people involved, I've just put the kind of institutional leads for the project because we all like to see pictures of who we're dealing with. Dave Jones from Newcastle is the overall lead. Okay. Dave Jones from Newcastle is the overall lead, and there's a lead person in each of the participating institutions. I won't dwell on that. The whole LifeArc Centre is quite complex and consists of 8 work packages, and I'm not going to attempt to talk about it in any great detail. I'll just mention a couple of things we're doing which are not trials before talking about the trials bit. One of the big things is a recruitment portal. So essentially, it's going to be a database which will contain information from patients with rare diseases and trials for rare diseases. So it's a way of trials to find patients and patients to find trials. That's that's going to be developed during the course of the project and will be a resource going forward for trials to use. Patient-reported outcomes is also a neglected area, and there's a team within the collaboration who are looking at patient-reported outcomes and developing those for rare diseases. And trial facilitation, taking away the barriers, the administrative barriers to making trials happen in rare diseases is another part of it. The bit I'm actually concerned with, what I want to talk about, is the trial design and delivery part of it, which is what Tori and I are both involved with. So what we have is a dedicated team to support design, management, and analysis of clinical trials in rare diseases. There are 3 clinical trials units involved in the collaboration in Birmingham, Newcastle, and the Northern Ireland CTU in Belfast. And our plan is to develop innovative trials for rare diseases with the ultimate aim of improving the evidence base, improving clinical practice, and improving the outcomes for patients. The intention is that the CTUs involved will take on management of these trials. So there's support for all stages of the conduct of trial, from trial design, funding applications, trial management, analysis, and reporting. So the whole trial life cycle. We are all academic institutions, but we are very cognizant of the fact that registration studies are going to be an important part of this for drug companies. Now, in Birmingham, one thing that we've done is started using we started running trials, academic trials, according to a model that we call fit for filing, which is basically a way of running academic trials to industry standards so that companies can then use them for regulatory submissions. That includes a number of modifications to the standard way that we do trials, and tends to involve a lot more money as well. And we intend to offer that to people as a possibility, so we can run trials to registration standards, so that we can take away one of the barriers to getting effective treatments into practice. The people leading the trial design and delivery, again, there's an institutional lead for each work package, and these are the ones for this one. That's me on the left, in case you're wondering. James Wason is leading it in Newcastle. He's actually giving a talk in parallel session about this and innovative trial designs. And Mike Clark is somebody who's very well known in the kind of trials area, may be familiar to some of you, who's leading it in Northern Ireland. I was just going to say a word or two about innovative methods that we're planning to try to use in some of these trials. Platform trials has become a big thing, and it's essentially a way of making your trials more efficient by running multiple trials in parallel. There's lots of ways you can do this. The common theme is that you have some kind of master protocol that encompasses multiple interventions or multiple disease groups, and obviously gains in the efficiency there. Compressed phase trials is something Tori's mentioned already. We want to try to compress trials to make trials happen more quickly by incorporating into one project everything from phase 1 up to phase 3. There's lots of ways you can do that. External control groups is another thing Tori mentioned as part of the CAPTIVATE project. Again, multiple ways you can do that, but rarely done in real life. And in rare diseases, there's obviously an imperative to try and get the treatment to as many patients as you can. So if we can use external data, then we probably should. And lastly, efficient use of patient data. There's lots of ways. One of the things we're really bad at in trials is using data efficiently. We collect lots of data and tend to compress it down. But we want to try and find ways of using data more efficiently by using more complicated statistical methods. That's more or less it. We're looking for trials. So if you've got ideas for trials, please talk to us. The idea is that trials will come into the collaboration for full management, but other levels of collaboration are possible if people are just looking for help with trial design, help with statistics or whatever. We're willing to talk about that as well. The processes are still in development. It'll all be up on the website soon. So I should just leave you with the website address and our addresses. If you have any trials or anything you want to talk to us about, please get in touch and don't hold back. Thank you very much.